My name is Dr. Lovely Thomas. I'm working as a registrar in Calderdale Royal Hospital. So this is my audit on obstetric anal sphincter injuries. So the objective of this audit was to evaluate the obstetric anal sphincter injuries in our hospital over the last 1 year and to find out the incidence and the risk factors of obstetric anal sphincter injuries and the methods to reduce the incidence. So the method was, it was a retrospective audit, and we examined the case report of all the women who sustained obstetric anal sphincter injuries over the last 1 year. That is from 1st January 2023 till December 31st, 2023. We analyzed the demographic data of the women who had the obstetric anal sphincter injuries, reviewed the mode of delivery, operator status at the time of delivery, and reviewed the use of episiotomy. So the results were the total number of obstetric anal sphincter injuries over the 1 year period in our hospital was 57 cases. So the total number of normal deliveries in our hospital, including the spontaneous vaginal delivery and the instrumental delivery, is 2736. So which constitute around 2.08%. So the obstetric anal sphincter injuries constitute 2.08%. So when compared to the national average in UK, it is less than the national average in UK, which is about 2.9%. So coming on to the different types of obstetric anal sphincter injuries, the most common type in our hospital was type 3B, which constituted around 49.1%. So in that diagram on the right-hand side, there is the percentages of the different types of the sphincter injury. Type 3A tear, where less than 50% of the external anal sphincter fibers are torn. And in our audit, it constituted around 31.5%. Type 3B was the most common tear, which involved more than 50% of the external anal sphincter, and it was 49.1%. Type 3C tear, where external anal sphincter and internal anal sphincter is torn, and it constitutes 10.5%. And type 4 tear, which is the most complex type of sphincter injury, it constituted 8.7%. None of these obstetric anal sphincter injuries were associated with rotational forceps. And when we analyze the risk factors of obstetric anal sphincter injuries, the risk factors were direct occipital posterior position, shoulder dystocia, sequential use of instrument, tight perineum, compound presentation, short perineal body, and quick delivery of the fetal head. So our recommendations were, we stressed the importance of antenatal counseling regarding obstetric anal sphincter injuries and its impact on the quality of life. Because even though the obstetric anal sphincter injuries, they are repaired, the ladies will have long-term consequences. So during our antenatal class, we stressed the importance of obstetric anal sphincter injuries and the methods that we use to prevent the obstetric anal sphincter injuries, like manual perineal protection and episiotomy. Because when the women, when they come in labor, during the second stage of labor, we don't have sufficient time to explain all these things to the ladies. So we need to use our antenatal counseling classes. The second recommendation was the importance to assess the perineum prior to the delivery to identify short perineal body and scarred or tight perineum, so that we can plan in advance whether we need to put an episiotomy or not. So usually, like most of the ladies, they have more than one vaginal examination while they are in labor before proceeding to the second stage. So each of those assessment, we need to assess whether it's a tight perineum or whether the perineal body is short, so we can plan in advance. Then adequate training for the staff in performing the episiotomy at the correct angle, that is at the 60-degree angle, and also suturing of the episiotomy. And to make the staff aware to continue giving the manual perineal protection till the delivery of the baby's shoulder. So we are all aware that we need to provide manual perineal protection at the time of delivery of the head. But sometimes we completely forget that after the delivery of the head, we need to apply, we need to continue applying the manual perineal protection in order to prevent obstetric anal sphincter injuries while delivering the shoulder. So there's a picture at the bottom which show the technique of doing the manual perineal protection, where with one hand, usually with the dominant hand, we need to provide the manual perineal protection. Usually in our hospital, we use the Finnish grip, where the middle finger, ring finger, and the small finger, it supports the perineal body, and the thumb and the index finger will support, will be over the labia majora. And with the non-dominant hand, it will be over the head of the baby to prevent this hyper extension of the head, thus preventing labial laceration. Then ask for help in supporting the perineum if needed. In a hospital, usually the surgeon will perform both the perineal support and the delivery of the baby. So if the surgeon feels that it's very difficult to do both simultaneously, we need to ask for help. We need to ask our assistant to support the perineum. Meanwhile, we'll do the delivery of the baby. Thank you. Any questions?